So reaction time, normal change of aging, right? It slows down, but if we do things like mental aerobics, cognitive exercises, that can be really helpful. I do Wordle every day in the New York Times to keep my mind challenged a little bit, along with the everyday activities I do. Exercise, any kind of mindfulness practice, meditation could be very helpful for people, but any mindfulness practice. Nutrition, video games are great. A lot of people like Wii and other games, so if the person's interested, I would encourage them to do that. And of course, the home safety checklist that will give them information on every room and changes that they need to make to keep their home environment safe becomes also an important piece as well. So in my role as an OT, I deal with all the things that we've just been talking about, but so do many other professionals. But they're an integral piece. But here's something now very unique to my profession, and that's using everyday activities therapeutically, right? In addition to exercise, which occupational therapists will use, but we'll also use activities. We choose activities that are meaningful to the person, so it's client-centered, and we understand how to use them. So how do I figure out the activities, right? Because if I'm meeting someone, how do I develop that history of what's meaningful to that person? So what I will do is say, hey, tell me about a typical day, about the things you want to do, things maybe that you need to do, or maybe that you're expected to do. And we'll talk about that typical day. And we'll identify those activities. And then I'll even say to the person, come up with 4 or 5 that are most important to you. So I know that I make sure I'm addressing those issues. And this is very much in line with the 4M's framework, which a lot of people use, right? Age-friendly, like if we're going to work and really provide healthcare that's right for older adults, we want to look at those 4M's, what matters, medication, mentation, and mobility. And in my role as an OT, certainly we're dealing with what matters, we're dealing with mobility and mentation from the point of view that if I can help that person remain engaged in activities that are meaningful to them so they're not disengaging, I can definitely have an impact on the mental and behavioral health. And to do that, OTs are trained in what's called activity analysis. So any activity, think about putting on a shirt. What does it take to do on a musculoskeletal level? What does it take to do on a cognitive level? What cognitive skills would be important? And when we're looking at a piece of clothing, what does that particular blouse or shirt mean to that person? Maybe a particular activity, item of clothing has a certain symbolic meaning to a person, right? So all of that's taken into account, and that we look at the challenges, breaking it down on those levels. What does it take to do something so that if somebody has a limitation, but I want to use that activity, I can modify it a little bit to use it to challenge them in all those underlying issues that might be putting them at risk, let's say, for a fall. Let me give you an example of what I mean. Years ago, I was working on the brain injury program, and I was working with a engineer who had had a stroke, and he loved working with his hands. He was retired, and he had had a workbench in his basement, and he liked to build things. Wood was his passion. So let me go to what his clinical issues were, and I'll come back to his interest. So from that stroke, he had balance issues, endurance issues. He had a left inattention. He had issues with fine motor coordination and spatial relations. So if I did TheraX with him and I wanted to do a balance exercise, after 2 minutes, he'd say, that's it. Or an endurance exercise tied into more therapeutic exercise, he'd go, that's it, after a couple minutes, if that long. So I found this birdhouse, and I said, how about we put this together? So I found a high-low table, brought it up high, wouldn't let him lean against the table. I spread out all the pieces, gave him the instructions. I said, let's build the birdhouse. So he had to look at the instructions, put the pieces together. He had to then use little nails and the hammer to put the pieces together. If he couldn't find something, because it was spread out on the table to his right and his left, he would say, I can't find it. And I would say, oh, so what's the issue with your vision? Oh, I don't notice things to the left. He had good awareness. He'd go, oh, there it is. And he'd pick it up. So in the context of that activity, which was meaningful to him, I addressed all those key clinical issues that you see on the screen. Now, if you didn't know anything about my profession, and you didn't know all the other things I was doing that might be more familiar to you, you'd walk by the room and you might go, oh, isn't that sweet? They're doing arts and crafts. But really, it was an activity. In the context of this real-life activity, we challenged his nervous system in all these different contexts. And we know from motor learning theory that that's really to help the nervous system to be able to adapt and generalize and work in different contexts. We want to bring in as much variety as we can to challenge the person, in this case, in all those different issues you see on the screen. And he stood for the first time 10, 15 minutes before even asking for a break, because it captured his attention. It was meaningful to him. So now I want to show you in a more therapeutic environment in terms of not always building a birdhouse, but certainly I've done things like that throughout my career. I want to show you how using an everyday activity, we could be addressing a bunch of different skills. So here's a picture of me, right? And I'm in the occupational therapy little ADL section of the classroom that we have. And you can see me with the walker, and I'm reaching for something on top of the refrigerator, and I'm going to put it in the cabinet. Right? So I would do this with the client, something like this. I would adjust it to make sure it's just the right level of challenge, not too easy, not too hard. So I get something else and I put it up. Then I go to the other side, put it up. So when you looked at that, which clinical issues are addressed in that activity? Upper extremity range of motion, upper extremity strength, balance, postural control, endurance, gross motor coordination. So which of those skills were addressed in that activity? Now, I wish we were live so we could sit and talk about it, but we can't. So all of them, right? Let's look at this activity. So here I'm approaching the refrigerator. I open it. I'd be teaching the client how to do this with the walker, of course, to do it safely. Position the walker so you maybe can't see it's blocking the door so the door can't open. It's also stabilizing the walker there because that door can't move the way it's designed. Reaching in to get something out of the fridge. The bag is there so I can put something in the bag after I take it from the refrigerator to take it to the countertop, let's say to make my salad. Reach in, put it in the bag, back up, close the door, and it's going to stop here, I think. Then I would turn and walk towards the counter. Okay, so look at the clinical issues here. Just read them on your own for a moment. Functional mobility and ambulation, I think, was added here. So what clinicals are addressed here in that activity? All of them. An important thing is I don't want to just educate the person I'm working with to use that walker to go 150 feet independently. That's important. But can they use that walker in the context of everyday occupations to get something out of the refrigerator, to bring it back to the counter, right? That's a lot of different kinds of movement. So it's not just about walking a straight line. Or getting something out of the closet, reaching up, taking the clothing off the dowel or the hanger off the dowel, draping it over the walker, bringing it back to the bed to get dressed. All these things are in the context of what an OT would do. So here, sticking with the kitchen, let's say I have to fill a pot, pretend that's a pot, and I'm going to make some pasta and bring it over to the stove, right? Have the person practice, there's a countertop in their home, so let's turn the walker, do that. Now with one hand, push it, put the hands back on the walker, move the walker, and then push the pot again until you get to the stove. So I think because occupational therapy uses these real life activities therapeutically, so we educate the person safe practice with any device we give them. We are also working on all those clinical skills that we need to be addressing for that particular person. And I want to share this study with you that was done in 2017. It was done in an acute care setting. Higher hospital spending on OT is associated with lower readmission rates. And I'm going to read this. We found that occupational therapy is the only spending category where additional spending has statistically significant association with lower readmission rates for all three medical conditions: heart failure, pneumonia, acute myocardial infarction. One possible explanation is that OT places a unique and immediate focus on a patient's functional and social needs, which can be important drivers of readmission if left unaddressed. So many people have to discharge, fall, rush to do something. We're not aware sometimes when we're discharging someone if they have a subtle cognitive issue that maybe like cabbage surgery. Sometimes people have a mild cognitive issue because of an anoxic event that may have happened during that procedure. But in the hospital environment, if we don't challenge them in the right way, because the environment's so structured, we won't notice it, then we send them home, and there's this subtle change in the cognition which puts them at a greater risk for a fall. But if we can work in the context of bringing the things I've been sharing with you, whether it's in the hospital setting, a clinic setting, or the home, that's that unique contribution that I'm sharing with you. Some of the other things, just a few more things, we're wrapping up soon, to make a big difference. Someone has balance issues, look at the picture on the left, maybe bad arthritis as well. Using like a T-cart to transport things from the kitchen counter to the table, right? That can make it easier. If the person, picture on the right, has a couch they love, but it's really low, and maybe they have MS and have weak legs, sofa risers. They could go underneath the couch. They come in different sizes, 3 inches, 4, 5. And they make them, those are really ugly ones, unfortunately, but they do make attractive ones that can, again, bring the height up and make it safe for the person to use that couch. The top right, a tub bench for those people that have a bench, a tub that they have to step into. You can't put grab bars in, let's say, for some reason, or even with a grab bar stepping in, it might not be safe. A tub bench where the two legs are outside the tub, 2 legs are inside. They can sit outside, scoot over, and bathe safely. Grab bars, strategically placed, can make a difference. 3-in-1 commodes. This is a picture in the OT classroom, but those could be put bedside at night to make it easy for someone who goes to the bathroom a lot in the evening to just sit up and transfer right over to the 3-in-1 commode, which would have a bucket attached to it. That bucket could be removed during the day and put over the toilet so that it's height adjustable. We can figure out the right height for that person to make it a safe transfer on and off the toilet. And then there are technologies that exist. There are pendants and all these smartwatches now that will identify if you've fallen and will contact someone directly, or you push the button on the pendant and you can speak with someone for those people that can afford that technology. Then there are bed alarms if the person maybe has cognitive issues and is unsafe, and we want to know if they get up out of bed or a wheelchair. A sensor can be placed on the bed or the wheelchair, and when they get up and move, we will at least have a warning, and hopefully we can prevent something bad from happening. And one of the last things I want to share with you, and something I don't think we do enough of, is educate people how to get up from the floor if they've fallen. I want to go back to the fear of falling. One of the major factors for the fear of falling is that someone is very fearful of the fact that if they fall, they won't be able to get up. So practicing that with them. So here you can see the person's fallen. I say, first, make sure you're okay. If you feel like you're okay, turn to your side. If you can, get to all fours and find something stable, a chair, a solid coffee table. Approach it. Put your hand on it, one hand on it, then both hands, and then if you can, you pivot up to sit on it. But if they have a pendant or the watch, or I educate people to keep their cell phones with them at all times if they can. So if they fall, it's there with them and they can make a call if they can't get up. But this is really an important piece, because if people know they can get up from the floor, that can give them a lot more confidence. So globally, things we can do. We can educate them about good body mechanics for joint protection, which I really didn't address. Give them cognitive exercises, do home modification, give them a home safety checklist, give them simple DME, durable medical equipment, if possible, like a shower chair, a tub bench, a 3-in-1 commode. That can make all the difference for some people, or whatever assistive technology that might work if it's affordable. Exercise, finding exercise they like that they'll do, diet, sleep, all those pieces together hopefully will contribute to social activity and engagement. And in my role as an OT, that's an integral piece, is to help that person to re-engage in all meaningful activities, or as we call them, occupations, things that occupy our time that are meaningful. Here are some resources here in New York City. We have the New York State Department, New York City Department of Health and Mental Hygiene, the New York City Department of Health and Mental Hygiene. I have it there twice. So take a picture of this with your smartphone, AARP. And then a particular home safety checklist that I like is the last one there, the Minnesota Council Health Safety Checklist that you can get online. The only problem is I only can find it in English, so if you like it, then you could have somebody translate it for you. It's a very simple, clear one, and I have found it very, very helpful. And I just want to end on this note that although, again, I've been emphasizing OT's unique contribution, I want to come back to what I started with, that all of us, right, play an important role. All of us have a unique contribution. So I'm thrilled to be a part of this series where we get to listen to each other, start conversations. And the more we do that, we all know, the better we serve our client. I grew up, when I say I grew up, in my OT career, I started in a facility that had an interdisciplinary model. That was the beginning of my OT career. So I saw the value of that from the very, very beginning. So here are the references. And I want to thank you all for joining me, and have a good day.